Hello, everybody. My name is Connor. Welcome to this meeting on biologics for chronic rhinosinusitis with nasal polyps, titled The Who, When, Why, and Which One. It is my pleasure to introduce Dr. Christine Franzese. And yeah, doctor, thank you so much for being with us.
Thank you. So just let me know if you can't hear me or see the slides, but I'm going to get started. So I'm going to introduce myself. My name is Christine Franzese. I am a clinical professor. I'm also the director of allergy, and I'm at the University of Missouri in Columbia in the Department of Otolaryngology. I am a sinus surgeon. So I focus on sinonasal disorders as well as allergies. And I do have some disclosures here. So I've been on some advisory boards, some research. I have some research funding, and I've been on some speakers bureaus. Some of these are relevant to this talk tonight. So we're going to start with our learning objective. So we're actually looking at some patient cases. So we're going to take a patient-centric focus to this disorder. We're going to look at the physical, extranasal, and some of the psychosocial aspects of the disease burden for each patient, maybe something we don't always think so much about. We're going to look at best practice criteria, either for recommending sinus surgery or biologic therapy, or maybe when systemic corticosteroids possibly could be appropriate. And we're going to try to differentiate between a few new emerging biologic treatments. So let's kind of look at the disease burden that our patients may suffer from. So when we look at the different patient experiences, particularly those people who have severe chronic sinusitis with nasal polyposis, a lot of different aspects of their life are affected. Now, when we look at this particular slide, proximal and distal really mean, though proximal meaning those effects that are really caused directly by the polyps. Distal, those are maybe indirectly, such as your emotional well-being, feeling annoyed, things like that, your social life. We see that this disease has a broad impact on our patients, and a pretty significant one, not just directly on things such as sleep, activities of daily living, and tiredness, but also social life, work, feeling annoyed. So it really affects our patients in a large way. And some of these we may appreciate, and some of these we might not. There's also a big economic burden associated with this disorder. So it's estimated that the total annual economic costs are about $5.7 billion. That's a lot of money, as well as the indirect costs. So when you think, we talked about work being affected with the patient. So on average, we're talking almost 5 days of work missed per year. Again, that may be more or less depending on the patient's severity of disease and the other comorbid diseases. For those with inadequately controlled or very severe disease that's difficult to control, the indirect cost has been estimated to be about $7,182 per patient per year. So the total cost would exceed potentially over $15,000 per patient. So again, pretty significant costs, particularly when we think of these costs. We're thinking about inflation too, and we all know nothing is really getting cheaper anymore. So with treating this disorder, it's nice to know if our patients are having improvement with any of our interventions, whether it be intranasal corticosteroids, whether it be sinus surgery, whether it be a biologic. There's different particular outcomes that we can measure. Now, you probably have all heard of the SNOT-22 questionnaire. It's something that's very standardly used to assess sinonasal symptoms in research studies, as well as many people will use it in clinical practice. There's another one called the CRS Pro. It's a 12 patient item questionnaire that assesses the impact of symptoms in the previous 7 days. It's very concise, valid, and reliable, and it correlates highly with the SNOT-22. So the SNOT-22 can be a little longer to administer, particularly if you're doing it in clinic. If you want something a little more concise, there is this 12-item questionnaire, but both of these are valid ways that we could measure symptoms that are related to chronic sinusitis, as well as other like holistic psychosocial effects. Chronic sinusitis with nasal polyps is frequently associated with other comorbid conditions. So particularly the one that's most striking is asthma. Now you'll notice that even about 20-ish% of patients without polyps will have asthma. We see that about 60 to 70% of patients with nasal polyps will also have asthma of some severity. With patients with AERD or NERD, that's actually part of the definition of the disease is to have asthma. And you'll see about 20 to 30% of those people in your practice. And then allergies is a very common comorbidity in patients with nasal polyps, but also those without. So chronic sinusitis and patients with AERD or NERD, it occurs in about 20 to 30% of patients. There's some people that feel like every patient that has chronic sinusitis with polyps and asthma should have an asthma challenge. That's a bit controversial, but it's possibly something that you can consider, because with these patients with AERD, they tend to be symptomatically more severe, both in their asthma, becomes more difficult to control. You have an increased risk of death, becomes more difficult to treat, as well as the fact that they have these hypersensitivity issues to aspirin and NSAIDs. So they will also be reactive to those COX-1 inhibitors, but they'll generally tolerate COX-2 inhibitors safely. It also tends to make their sinus disease worse. They tend to have more severe polyp disease, particularly if you've ever done a FES on those patients with AERD or NERD. Their polyps tend to be more fibrous. They tend to bleed a lot more, tend to make a lot more mucus. So overall, having this diagnosis is very important, because it's a signal to you as the physician that this is going to be someone that is going to be more difficult to control, but also it helps with the patient when you do shared decision making to kind of set expectations for treatment. So consider, if you have someone with AERD, you want to consider aspirin desensitization followed by aspirin therapy. In those patients where they've been refractory to other medical therapy, this has been shown to decrease asthma-related hospitalizations and ED visits, decrease medication use, and will improve some asthma symptom scores and sometimes improve their sinus disease and symptoms. Many people will often recommend sinus surgery prior to desensitization. In fact, many allergists I know that will do aspirin desensitization will pretty much mandate that you do sinus surgery prior to desensitization, because if you do desensitization while they have large polyps, they're just more at risk for adverse reactions. So it's a lot safer if you do sinus surgery and then afterwards, later on, do the desensitization. So now we'll get into the pathogenesis and the molecular drivers of this. So just the gestalt of this slide, there's a lot going on here. And the good thing is, as our understanding of this disease has progressed, we've really got a better idea of what cells, what mediators we want to target for potential therapy. But we also see that these pathways have become more complex. So when you look at this slide, the take-home point of this that I want you to get is this is an orchestra. This isn't a bunch of instruments that are playing in solo. This is an orchestra that's making music together, and everybody has a part. And there's a lot of back and forth. There's a lot of one-way arrows on here, but what we kind of, to make these diagrams very simplified, there's a lot of interactions. There's a lot of feedback that goes on. It starts at the top, and in general, there are some triggers, so fungus, irritants, things like that, that will get the orchestra started. Then you have these alarmins, thymic stromal lymphopoietin, IL-33. There's a few others that kind of get the conductor for the orchestra going. And then we have the orchestra components. So we have, T cells, we have eosinophils, we have mast cells, we have B cells. There'll be different types. There'll be T helper type 2 cells. There'll be innate lymphoid type 2 cells. All of these are kind of interacting. They're making their song, they're making their music. And on a whole, in the end, it's going to grow a polyp. It has a lot of different effects, including like fibrin deposition, epithelial damage, as well as increasing mucus production. But on the whole, I do want you to, when we look at these things, what we're going to target, because in towards the end of this presentation, we're going to talk about different biologics that target these things. It's not just as simplistic as targeting a couple different mediators. This is a very complex process. It also tends to be broken down into 3 different endotypes. So we have type 1, type 2, and type 3. Type 1 is driven by interferon gamma and IL-12. It's a more neutrophilic phenotype, and it's sort of dominated by T helper cells type 1, natural killer cells, And we really see more purulent nasal discharge with this. It's more frequent to find this endotype in chronic sinusitis without nasal polyps, at least in the Western world. There's also type 3, which is really dominated more by the Th helper cell type 17. It's driven more by IL-17 and IL-22. Also has more purulent nasal discharge, and you can see this in either chronic sinusitis with or without nasal polyps. Now, certainly in the Western world, nasal polyps, asthma, the atopic disorders tend to be more type 2 driven. So these are driven by the Th2 helper cells, the eosinophils, the basophils, the mast cells, and you'll see those cytokines IL-4, IL-5, and IL-13. Again, these are all complex processes, and I want to emphasize this disease state is really more of like an orchestra because there are mixed endotypes too. There are people that may have a bit of type 1 and type 2, or type 2 and type 3. There are some people that may have all three of those endotypes. So we would like it to be nice and simple and straightforward. It isn't necessarily always. So to talk more in general terms, particularly in Western countries, chronic sinusitis with nasal polyposis without nasal polyposis tends to be more type 1, and chronic sinusitis with nasal polyps tend to be more type 2. And you'll see there's a higher association of those comorbidities that are associated with type 2 disease. So asthma, allergies, AERD or NERD, or a combination of those disorders. Interestingly enough, atopic dermatitis is also an atopic type 2 disease, but you usually really don't see that with chronic sinusitis with nasal polyps. It's pretty uncommon. So endotype phenotype associations with different presentations, when you look at different symptoms, so potentially when you start over on the left, sense of smell, reduced taste, you'll notice that that symptom complaint tends to occur more in patients with type 2 disease, as opposed to those patients that may complain of facial pain and pressure, more headache or migraine symptoms. Those are going to occur in people that are not having a type 2, a T2 endotype. Those with more pus, again, you're not going to see really that in type 2. It's going to be more present in either T1 or type 3 endotypes. So that can be helpful in kind of when you're trying to figure out what endotype a patient may or may not have. Again, it's not always perfect because there will be some mixed endotypes, but at least it gives us some place to start. So we're going to go over our first case. So this is someone potentially like you may see in clinic. So this is a 41-year-old male. He has a history of chronic congestion and facial pain. He has reported an increase in postnasal drip, which I mean, honestly, all my patients complain of postnasal drip, but his is worse. An inability to smell, and he's having some trouble sleeping. So his current medications, he's been using an over-the-counter nasal steroid spray, and he's been using it as indicated for a year. He has a prescription inhaled corticosteroid that he uses on and off as needed. He doesn't really have any other relevant atopic history. No notable family history, and you do nasal endoscopy, and you do visualize some polyps. So kind of just to throw this out here, how would you treat Alex? So this is an audience response question. So you can take a moment, and the different choices are, well, you could choose an intranasal steroid for regular use. The exhaled delivery system of fluticasone, short course of oral corticosteroids and continue his nasal steroid. You could do antibiotics with or without nasal steroids, or you could do functional endoscopic sinus surgery. Okay. Is the so I think the poll is closed. So we've got intranasal steroid for regular use, which that is part of the standard of care of chronic sinusitis with nasal polyposis, but he's currently on it. It hasn't really been working. You could consider functional endoscopic sinus surgery. We'll go over some of these algorithms. Certainly you probably want to work him up a little bit more, but you could potentially choose the exhaled delivery system. Potentially you might think about a short course of steroids, and you potentially could also discuss best with the patient. So it's a nice segue into medical and surgical management. So saline irrigations are also part of the standard of care. They've been shown to have some benefit, particularly large volume daily irrigations. There's no benefit from low volume irrigations or low volume nebulized saline spray. Intranasal corticosteroids are also part of the treatment plan for nasal polyps. So you can have nasal sprays as well as the exhaled delivery system, or some people will do installations of nasal drops. There's oral corticosteroids. This is really for the acute relief of severe blockage and loss of sense of smell. They're really not a great long-term treatment. Antibiotics don't have a huge role in this disorder. There's a prior randomized controlled trial that does demonstrate a small benefit using doxycycline, possibly due to the contribution of Staph aureus. But again, most antibiotics don't play a large role in this treatment. So the exhaled delivery system with fluticasone, EDS flu, I probably will just say that from now on, that's a bit easier. It delivers fluticasone to the sinus cavities as well as the nasal cavity in a different way than the regular intranasal corticosteroid sprays do. It's FDA approved in 2017 based on its phase 3 trials, particularly the Navigate-2 trial. There were 323 patients in that had moderate to severe chronic sinusitis with nasal polyps. They were treated for 16 weeks, and then it was followed by an open label 8-week to bring the study up to 24 weeks total. The polyps were reduced in size by about 1.3 compared to 0.6 in placebo. But I do want to call out that there have been a number of trials that are phase 3 trials that have been done for FDA, either for drugs or devices, and different polyp scoring systems were used. So I do want to point out that the polyp scoring system used in this trial was different from the ones used in the biologic trials, as well as those that were used for the stent. So polyps, about 25% of them were eliminated on one side by week 24 versus about 8.7% with placebo. Snot scores were improved. It's a negative number, but that actually indicates improvement because the lower number you have, the better you're feeling. And it decreased the need for surgery by about 62 to 67%. So oral corticosteroids, there's good evidence actually that they're effective. In fact, if you've used them in practice, you've seen that they actually do make a big impact on nasal polyps, but there's a lot of long-term advantages. There's also some short-term disadvantages and side effects with these drugs as well. They are definitely not first-line therapy, and they can be used in short courses for about 2 to 3 weeks as a last resort, particularly if the patients are really suffering or struggling. They can be very helpful in rather quickly improving the patient's symptoms, but they're not a great long-term option, and they're not going to have long-lasting effects. Once the steroid wears off, the patient's polyps are going to come back. In addition, certain populations like diabetics, they're going to have issues with their blood sugar, so you're going to want to make sure that they watch them very carefully. And there may be patients with glaucoma who have high intraocular pressures, or they're struggling with their intraocular pressures, that are going to have issues with the steroids. There's also lifetime risks of steroids. So this is the study by Price et al., published in the Journal of Asthma and Allergy, which looked at 2 cohorts of asthmatics. They studied them for about 20 to 25 years, and they basically compared a cohort of asthmatics that had never been exposed to oral corticosteroids to those that had been exposed to oral corticosteroids. And they found that there's actually a dose-response relationship for oral corticosteroids, and it's a lifetime cumulative thing. So each course of steroids a patient gets, each exposure builds on the last one, and it doesn't take much before you start to have an increase in these adverse events. So you see here, some of them are kind of obvious, like weight gain, type 2 diabetes. Some of them may be not so obvious, like depression and anxiety. Certainly when someone is on steroids, you can definitely see psychiatric side effects, but this is actually after the patient is off them, they have increased lifetime risk to develop these disorders. In addition, you've got renal issues, sleep apnea, other things, and you can start to see them at about 500 milligrams or half a gram. So that's pretty impressive. So it's something that we should consider when we are prescribing oral corticosteroids. Not that you should ever withhold them if the patient really needs them, but it's something we want to be mindful of. Alex is prescribed a short course of oral steroids and the EDS flu. And 60 days later, he comes back and he states that the oral steroids have really helped, but the postnasal drip, his lack of sense of smell, and his facial pain have returned once he completed the therapy. A CAT scan is performed and you see extensive opacification of the sinuses. So Alex is presented with the following options for a trial of therapy. So just kind of thoughts, which therapy would you recommend? Would you prescribe low-dose oral corticosteroids, consider functional endoscopic sinus surgery, or initiate a biologic therapy? All right, so Alex is presented with those options. Which would you recommend? So he's prescribed, so you've already actually done the low-dose oral corticosteroids. You could do faster, you could do biologics. Well, sinus surgery, I'll argue, that is part of the treatment paradigm of this disorder, and he has not had any surgery. And many people will improve with sinus surgery. So let's talk about that first before we get into biologics. So functional endoscopic sinus surgery, this actually can provide pretty instantaneous relief from their nasal airway obstruction. It's one of the things to consider when people have especially large polyps, because you can really eliminate or get rid of most of their polyp disease pretty quickly with sinus surgery. Now, there is sinus surgery is not a cure. Medical management is still part of this disorder, including saline rinses. You may add corticosteroids to those rinses. Intranasal corticosteroid sprays are still part of this treatment. So medical management is still part of the treatment, but surgery has a lot of benefits, and it is part of this treatment plan. With the steroid-eluting implantable stents, those will deliver mometasone to the ethmoid sinus over about 90 days. Now, for a patient to be candidate for those stents, they actually have already had to have had one surgery, and that surgery had to include a prior ethmoidectomy. So that's a potential device that is generally used in clinic that you can insert into the ethmoid sinus, and it is FDA approved for polyps. So this is looking at the evaluation of sinus disease severity pre and post FES at different time points. They're looking at modified Lund-Mackay scores, as well as SNOT-22. So it's a little bit difficult to see the improvement. So the median here on the pre is marked in red on both sides, and the blue is the post-FES. So you can see both their modified Lund-Mackay scores as well as SNOT-22. SNOT-22 is pretty meaningful. Anything that's 40 or above is severe disease. So you can see lots of patients had severe disease, and certainly the median was at 50. And then you see a big drop in their SNOT-22 scores afterwards. FES and medical therapy have been shown, again, to help patients versus just medical therapy alone over 12 months. So this is a randomized controlled trial that looked at mean SNOT-22 scores. Again, that's good. It's a validated, reliable quality of life measure. And you can see at the baseline, both patients that were in the medical therapy group as well as the FES group started out over that 40 scale. And then you can see over the 3, 6, and 12 months that actually the FES group improved a little bit more than the medical management group. So limitations, corticosteroid usage, surgery plus medical therapy was used, and there was a cumulative mean dose of steroids listed there. There was an inability to mask during this trial. And then there was also crossover, so about 20% of the patients in the medical therapy group crossed over to the FES group. And then the sample size, there's too few patients in the subgroup, and it's actually a short follow-up period. So let's go over the economic analysis of oral corticosteroids versus surgery. So the break-even threshold for surgery was favored over medical therapy based on the impact of adverse events that occurred when there was more than one oral corticosteroid course given every 2 years. And when you think about that price study that we looked at the data, there is that lifetime cumulative risk that sort of adds on top of it. So the threshold number of systemic corticosteroid courses per year at which the risk of medical therapy exceeded the risk of surgery, it's the lowest for just nasal polyps alone. So if you just have polyps alone, it doesn't take many courses to really exceed the benefits of oral corticosteroids, and really where surgery is favored. You have comorbidities, it goes up a little higher. So the long-term adverse events with oral corticosteroids outweigh the benefits in most patients, particularly those that don't have comorbidities, that just have nasal polyps alone. So the long-term oral corticosteroid use is not a good choice. So guidance for treatments, who, what, when, and why. Well, there's a lot of algorithms out now to help us kind of manage how we should treat patients, where we might fit the EDS flu, where we might fit intranasal corticosteroids, where we might fit surgery, where we might fit biologics. So this is one example of an algorithm. This was a multidisciplinary group that got together and kind of came up with a management strategy. So you can see the majority of patients will proceed to sinus surgery. Again, you want to consider like complete sinus surgery, and depending on the patient's disease extent, you may vary your surgery. There's postoperative management, so saline steroids, intranasal corticosteroids, and then if they fail, symptoms recur, symptoms persist, you can use a shared decision-making model to consider these other options. So certainly if the patient is an AERD or NERD patient, you may consider aspirin desensitization. You may consider biologics, depending on their comorbidities. You may consider revision sinus surgery. There's also the steroid implant, or consider another burst of oral corticosteroids. The minority of patients, which may have a contraindication to surgery, they may have very poorly controlled asthma, or they may decline surgery. They're just not interested in it. And there may be patients that have already had surgery. Certainly we've seen patients in our clinic that have had, 2, 3, 4, 5. I've had one patient that had 10 sinus surgeries. So they may be more interested in looking at an alternative, and that would be something like considering a biologic. So this is one potential guideline for when a biologic treatment may be indicated. So this is from the EPOS group from 2020, looking at the indications for potential biologic therapies. And I do want to point out that this is for patients who've been screened. They have bilateral nasal polyps, so this is not unilateral disease. This is not a malignancy. These are people that are known to have bilateral chronic nasal sinusitis with polyposis, and they have already had sinus surgery. So they require 3 different criteria. So what you're doing is looking for evidence of type 2 inflammation, either an evidence of blood eosinophils, or total IgE elevated over 100, or if you are able to send nasal polyp tissue to your pathologist, and you have a pathologist that will cooperate with you and actually give you an eosinophil count, if they're able to tell you if there's 10 or more per high-powered field, that can be meaningful evidence of type 2 inflammation. I'm in an institution where I'm not always able to get that information. So again, someone that has needed systemic corticosteroids, or they have a contraindication to it. So in this, you're looking for someone that has had at least 2 courses or more per year or they've been on daily low-dose oral corticosteroids for at least 3 months, then you're thinking about a biologic. SNOT-22 scores above 40 or above, again, that indicates severe disease. There is nosmic on smell test. Again, it's going to depend on which test you do. Or they have asthma that's comorbid asthma. So of the different FDA-approved biologics that we currently have right now, we have dupilumab, which acts on IL-4 and IL-13. That's its target. Omalizumab, which is an anti-IgE, and Mepo, which is an anti-IL-5. So for all of them, they are all indicated for adult patients. None of them are indicated for anybody below 18 years of age. And we're going to touch on their different phase 3 trials. So there's Sinus 24 and 52 for Dupi, there's Polyp 1 and 2 for OMA, and then Synapse for mepolizumab. And you can see the listed number of patients. The safety across all trials was pretty similar. When we look at the different euphoria criteria for considering a biologic, now we looked at EPOS. This is going to be euphoria. Again, this is also another European group. So this has to do with, again, patients that have bilateral nasal polyps, not a unilateral disease, not something else going on, and it'll stratify them between those patients that have had surgery already and those who have not. For those who have already had surgery, similar to the EPOS, they're looking for 3 criteria. For those who have not had surgery, they really require 4 of these criteria. So again, evidence of type 2 inflammation, similar to what's listed prior, the need for systemic corticosteroids, again, 2 or more courses in the past year, significantly impaired quality of life, that's something you would get from a SNOT-22 or another quality of life questionnaire, significant loss of sense of smell, and again, the diagnosis of comorbid asthma. So when we look at the different options for Alex, well, if you look at the multidisciplinary consensus, he's a candidate for surgery based on his profile. For euphoria, he meets the criteria for biologics, despite the fact that he's surgery naive, because he meets 4 of those criteria. And for EPOS, he does not meet the criteria for biologic therapy. Similar to the multidisciplinary consensus statement, you're really looking for someone probably that's had surgery already. But again, you want to talk to the patient, you want to make this decision together. So shared decision-making is important. So now we're going to get into the different biologic treatments. So we're going to start with dupilumab. Dupilumab was the biologic that was first approved by the FDA for the treatment of chronic sinusitis with nasal polyps. It was 2 phase 3 trials. These were all adult patients. There was no requirement for surgery. In this trial was the Sinus 24 and Sinus 52. Here we see it did meet its primary endpoints, both of them, which were change in nasal polyp score, as well as improvement in nasal congestion. The graphs that are lifted towards the left are from Sinus 24, where they got treatment for 24 weeks, and then the rest of the study, they were off treatment. So you will see there was improvement in the nasal polyp scores, about 2, and then off treatment, there was some regression towards the mean. Same thing with their symptoms of nasal congestion or obstruction. And then those in Sinus 52, you'll again see that improvement in nasal polyp score and congestion throughout the trial. So overall, the nasal polyp scores improved by about 2 points, as well as their nasal congestion scores. This is looking at the need for reducing surgery or the need for oral corticosteroids during these trials. And so again, this is over 52 weeks. So this is looking at a pooled analysis, and you can see that those people who were in the treatment group compared to the placebo group had a much lower rate of needing sinus surgery or an oral corticosteroid. So there was statistically significant improvement in the need for surgery or oral corticosteroids. And then this is, I think this is probably a post hoc analysis of that data, looking at efficacy of those patients in previous FES. So they sorted it out by the patients who didn't have surgery, because again, there were patients who didn't have surgery were allowed into the trial, and then as well as the time from surgery. So some patients had one surgery, so you can see some patients had 3 or more. Some patients had surgery more recently, and some patients had surgery, if they had surgery, 10 or more years ago. This is a very helpful and important stratification because, as we know, sinus surgery has actually changed over the years. And the way we do it now is very different from the way it was done, let's say, 20, 25 years ago. But you'll notice, even with this stratification, that all comers, regardless of whether they had surgery or not, and regardless of how long ago it was, did skew to the fact that it favored dupilumab over placebo. Omalizumab, this is the open label safety study. So you'll see data from Polyp 1 and Polyp 2. This study, both of them were followed by an open label treatment period where everybody, including those people who were on placebo, got the drug, and then they stopped it and they followed the patients for another 6 months. And so similar to prior, like with Sinus 24, when they were on treatment and they were off treatment, you can see that compared to placebo during the treatment period with Polyp 1 and Polyp 2, there was a statistically significant improvement in nasal polyp size as well as nasal congestion. When everybody went on the open label period, everybody improved, including those patients. You can see a big improvement in those patients that were on placebo. And then when they were off of it, there was regression towards the mean, so people got worse when they were off it. You can see the nasal congestion score mimics this as well. And again, I want to point out the polyp scoring system for these biologic trials are going to be different from what was in the EDS trial, the EDS flu, as well as for the steroid stent. There were different scoring systems all around. So overall, omalizumab also reduced the need for surgery. So in addition to meeting its primary endpoints of reduction in nasal polyp size, as well as nasal congestion scores, there was an improvement in the need for surgery, particularly in those patients that had a score of 4 or less on total, or less than 2 on each side. And there was also improvement in their SNOT 22 scores. Now we get into MEPO. So mepolizumab had a single trial, the SYNAPSE trial, which was a phase 3 trial. This one is a little bit different because all comers had to have at least one sinus surgery. And unlike what you see in the dupilumab trial, that surgery had to be recent. It had to be within at least the last 10 years, and it could not be balloon sinus surgery. They did meet both primary endpoints in this phase 3 trial. This is a categorization of their responder rate. So the slide on the left, the graph on the left is showing you that when you kind of take the gestalt of this data, about half of the patients either who were on the treatment group either had no change or got worse. Now that was much more, that was statistically significant in the placebo group. More patients either had no change or got worse. But about half of the patients actually had a significant response. And you'll notice what's really interesting is that some people had a decent response, and that about 10% had a really good response. So a 4 or a 5 point improvement. This is also on the other side of the graph is their improvement in their nasal obstruction scores. Now, this score was different from the scores talked about in the other trial because this was a visual analog scale that was at 1 out of 10 points. So that's why they have a different stratification. But you'll notice that on whole, those people who were on treatment had a better rate of improvement in their nasal obstruction score compared to those who were on just the placebo group. You will notice that in all 3 of these trials, there's actually a pretty significant placebo effect in some of the symptom scores, and that's because these trials all had people on standard of care, which was an intranasal corticosteroid twice a day. MEPO was also effective in reducing the need for surgery in patients. So again, this is a plot showing over the year of the study that there was a difference between the placebo group and the MEPO group in the need for requiring surgery, and that it was a much lower need in the mepolizumab group. There is no trial that directly compares these biologics. There is an indirect study based on systemic reviews of comparing these different biologics. You have to remember this is not a direct comparison. These are indirect comparisons. And so this is not a perfect study, but it gives you an idea of potentially the differences between these biologics. The way that this is done is all three of these biologics, dupilumab, OMA, MEPO, were all compared to a placebo. So they use the placebo as a way to indirectly compare them. You do have to be careful with this because the study populations between these were different, particularly with the MEPO group. Everybody had to have surgery and everybody had to have recent surgery. That was not the same with the other two, but it's still, this is about as good as we're probably ever going to do with comparing these drugs. So as you can see, as far as the sense of smell goes, dupilumab seemed to have the biggest response, the most improvement. Same thing with the SNOT-22. Well, all of them had improvement in their SNOT-22 scores. Dupilumab seemed to be the most favorable one. When we look at reducing the need for surgery, reducing the need for oral corticosteroids, and fewer treatment or adverse events, again, dupilumab seemed to be the most favorable one. But again, all three of these met their primary endpoints, and none of them had any major big safety or black box warnings. This is another indirect treatment comparison for dupilumab and omalizumab. And again, you can see this is a forest plot looking at polyp 1, which is on the top, sinus 24 and 52, which are the Dupi trials that are in the middle. And then at the very bottom is that indirect comparison. And you can see that, again, it tends to favor dupilumab for nasal polyp score, nasal congestion scores, and loss of sense of smell. So there are still some biologics undergoing phase 3 trials. There are actually some now in phase 2 as well. So Benra currently has an ongoing trial called ORCID. Astro's actually done and its data is published. Tezepelumab is the Waypoint trial, which is ongoing now. And then there's an Anchor 1 and Anchor 2, depemokimab, which is enrolling. It's actually enrolling now. And you can see the potential completeness dates. But like I said, Astra is already done. So now we have Samantha. She's a 42-year-old female. She presents with a diagnosis of chronic sinusitis with polyp. She's had previous surgery, and she's on budesonide rinse and has been doing them for the last 9 months. She's presenting to you with congestion. She's got nonstop sinus fullness, pain that will develop into headaches, and she can't smell. She does have asthma. She's mostly controlled on medium dose inhaled corticosteroids. She does require her rescue inhaler when she's very busy and running around, so it's probably all the time. And then she's got a CT scan, which reveals severe opacification of her sinuses. So potentially, how would you treat this patient? You could consider giving her a short course of oral corticosteroids, potentially do a revision FES on her. You could consider a biologic treatment. You could consider a short course of oral corticosteroids and revision FES or biologic. You get to do all of the options with that one. Or you can consider a steroid sinus implant. All right, so we have biologic treatment or a short course with revision FES or a biologic. This is something where I don't necessarily think there's a right or a wrong answer. Again, this is something you're going to have a discussion with the patient. Certainly, I don't think a biologic treatment is wrong because she's already had surgery. She's been compliant with her rinse, so she's having severe disease. But I also don't think revision surgery is off the table. Again, this is going to depend on what the patient wants. And then there's a lot of discussion about what kind of surgery patients need to have for a polyp. So I think any of those are on the table. So short course of oral corticosteroids in revision, FES or biologic, is also a good answer too. Again, she's having severe symptoms, so potentially she could get that short course and then follow it with something else. So surgery, polyp recurrence, and revision surgery. So as we kind of discussed, medical management is part of, not just pre-op, but post-op as well. So when we're talking about surgery, we're discussing nasal irrigations, intranasal corticosteroids. Potentially you may consider short-term oral corticosteroids. So there was a Galen cohort, which looked at those patients that were doing medical management consisting of this. And about 46 of these patients in this cohort required surgery. So nasal polyp recurrence after surgery. This is from the DeConda study. It's quoted in a lot of different decks. It was a good study done by different institutions. And they found that about 25 to 35% of patients at 6 months and 40% of patients at 18 months had recurrence of their polyps. Now, the caveat to that in that study was they had recurrence of the polyps. They didn't really say, what size they were. So even if the patient had just a tiny little polyp, that would be counted as a recurrence. So you do have to keep that in mind in discussing this study. About 33% of patients require repeat surgery over 12 years, and about 20% of patients will require multiple surgeries. So when you look at the median time to revision surgery, when you're looking at someone that has chronic sinusitis with nasal polyposis alone, the median time to revision surgery is 20 years. So this is something to consider in patients. That's a pretty long time prior to needing a revision surgery. So you'll see that time frame decreases when you add comorbidities. So I think this is helpful in decision making when considering a biologic. Certainly if patients have a comorbidity, that's a good reason to consider different therapies. But if someone has chronic sinusitis with nasal polyposis alone, again, putting surgery in your treatment algorithm is actually not a bad option, given that people can go a pretty long time between surgeries, and some may never need another surgery. So looking at Samantha, so she's our 42-year-old girl, female. So with the multidisciplinary consensus, if symptoms persist or recur despite FES, you may consider these other therapies. So she may be a candidate for revision FES. She may be a candidate for aspirin desensitization, the sinus steroid implant, or biologics. So you have a lot of potential ways you could treat her. For euphoria, she meets the criteria for biologics because she has more than 3. And the same thing with EPOS 2020. She also meets the criteria for a biologic. So you could consider a revision FES with her, or just as valid, you could consider a biologic as well. This is something, again, where you want to discuss with your patient. So this is where we get into shared decision making. So if you have failure of a standard of care of intranasal corticosteroids, saline irrigations, and possibly intermittent oral corticosteroids, you want to have this discussion about patients where they should go on a biologic, whether they talk about the EDS flu system or a surgical procedure. If they have failure after their first surgical procedure, whether or not there was a corticosteroid stent used or not, again, you're going to have shared decision making. Discuss with them, what are their goals? What would they like to achieve? What do they value? And people are going to have different things, again, depending on if they've had a failure of one or more procedures. And certainly if they have different comorbidities, you're going to want to talk to them about different options. This type of discussion becomes very important in females of childbearing years, especially those females that are looking to get pregnant and they have their uterus. A biologic, these are IgG antibodies that do cross the placenta, and they do potentially cross into breast milk. So if someone is planning to get pregnant or they are pregnant, you're going to want to consider that in your discussion of whether or not to initiate a biologic. So, and again, cost is another thing for these patients. So here we have different choices: the intranasal corticosteroid sprays, the EDS flu, surgery, and biologics. Starting from cheapest to most expensive, there are different advantages and disadvantages. Some of these are simple to use. Some of them have better exposure to the sinuses, like the EDS flu system. the EDS flu is a little more expensive than intranasal corticosteroids, and insurance coverage may be different. Surgery as well. Some people will have high deductible plans. Some people may not have insurance. Surgery is a little more expensive, but again, some people just need one good sinus surgery and budesonide rinses. And then biologics, these are very safe. They're FDA approved, they're easy to use. Many patients can do their therapy at home. However, these can be extremely expensive. And if you have somebody that doesn't have insurance or they have a high deductible plan, there are ways that you could still help with this, but again, the costs may be very significant to the patient. So we'll go over a few different questions now to kind of wrap things up and then look at our summary. So which of the following is more disease specific for chronic sinusitis with nasal polyposis? So of these three questionnaires, which one is the most disease specific for what we're talking about? So either SNOT22, SF36, or EQ5D. So it's not 22. This lecture talked about the CRS Pro, but that was in comparison to SNOT 22. So SNOT 22 is really the most, so good job. According to the EPOS 2020, in order to meet criteria for the need for systemic corticosteroids and consideration for biologic treatment, the patient should have which of the following? So one or more short courses of oral corticosteroids per year, or daily therapy for a month or more, 2 short courses per year, or long-term therapy of daily therapy of greater than 3 months, or greater than or equal to 3 months, or 3 short courses, 3 or more short courses per year, or therapy for 6 or more months. So a little bit of a split for this. It's 2. I mean, 2 or more courses of oral corticosteroids per year, or long-term therapy for 3 or more months. That's the particular EPOS criteria. So Tom is a 45-year-old male who has a diagnosis of chronic sinusitis with nasal polyposis and is currently taking a medium dose ICS for his asthma. He's been treated with the EDS flu and was previously on a daily nasal steroid. He underwent FES after losing his ability to smell and experiencing lack of sleep due to his nasal congestion. His smell and sleep returned after FES, but have since recurred, meaning his symptoms have gotten worse. What would be the most appropriate recommendation for this patient who's already had surgery and he's had recurrence of his symptoms based on the Euphoria guidelines? So would you give him a short course of oral corticosteroids? Would you give him the EDS flu spray per nostril twice daily, biologic therapy, or functional endoscopic sinus surgery? All right, so we got a little bit of a split, and I think both of these therapies are valid. So you could do a revision FES on him, since he's already had surgery. That's certainly on the table. But looking at Euphoria guidelines, he does meet indications for a biologic. So he's already had surgery. He has a comorbidity. He's on a nasal steroid already, and you kind of assume he's having severe symptoms. So he would meet those 3 indications for needing a biologic. So you could actually legitimately go either way with this patient. In an indirect comparison of available biologics for chronic sinusitis with nasal polyposis, which therapy demonstrated greatest effect on improving sense of smell and in reduction of SNOT-22 scores, the need for surgery, the need for oral corticosteroids versus standard of care? So was it mepolizumab, dupilumab, or omalizumab? So it was dupilumab. Dupilumab, and again, is an indirect comparison, but it showed the most improvement in the SNOT-22 scores and sense of smell and need for surgery and the need for oral corticosteroids. So dupilumab sort of triumphed in that indirect comparison. So overall, let's wrap up. So chronic sinusitis with nasal polyposis, it really causes a significant economic burden to our patients, as well as symptomatic burden. There are a lot of quality of life questionnaires for chronic sinusitis with nasal polyposis. The three main ones that we think about are SNOT-22. This is the longest, well, actually, it's not the longest one, it's the medium one, so it's 22 items. CRS Pro, which has 12 items, and the NPQ, which is 27 items. Adverse events of corticosteroids outweigh the advantages of their therapeutic value, particularly if they're very frequent or the dose duration is very high. There are a lot of studies actually that will show the adverse events of even just short-term, short courses of oral corticosteroids. Several consensus groups have given some guidance. So we've seen that multidisciplinary group, we have EPOS, we have Euphoria, sort of to try to help us figure out when we should recommend surgery for patients or biologics or other treatments. There are 3 biologics now approved for chronic sinusitis with nasal polyposis. There are current studies being done now, so it wouldn't surprise me if we had even more options available in the future. In the absence of head-to-head trials, indirect treatment comparisons at least give us an idea or provide some support for the selection of biologics. Again, you do want to be a little careful with those indirect comparisons, but at least it gives us a starting point for discussion with our patients with shared decision making. So I don't believe there are any questions right now, but if anybody would like to answer a question, I'd be happy to take any questions. And if you do want to ask a question, I believe there's like a button below the slides that you can click on. But if there's no questions, that's okay too. Well, thank you. Thanks everybody for tuning in, and I hope that you all have a good night.